Hi, my name is Ann Steiner. I'm an OBGYN from the University of Pennsylvania. I'd like to thank FORCE and especially Sue Friedman for inviting me to address you today. And I'd like to talk about the management of premature and early menopause for those who are eligible to take hormone therapy. There's another presentation during this conference for others who are not eligible to take hormone therapy in the management of menopausal symptoms. I have no disclosures. What we're going to talk about today is premature and early menopause. It can be natural, and there's a difference between natural and surgically induced menopause. There is evidence of increased morbidity and mortality with premature and early menopause, and there's evidence of the benefit of hormone therapy in early and premature menopause. But what are we concerned about? What are women concerned about? Well, we know from the Women's Health Initiative called the WHI that there may be an increased risk of some complications taking hormone therapy, but the question is whether we can extrapolate this to younger women. And there may be a fear that hormone therapy can increase cancer risk. And then we'll have a little summary at the end and talk about recommendations. So women go through menarche between the ages of 11 and 16, and then they start to produce estrogen in their ovaries, which continues until the time of menopause. The age of natural menopause is around 51 years old, at which point in time there's a gradual decline in estrogen. If women go into what's early menopause, which is between the age of 40 and 45, this estrogen curve is shifted over. So they go through the same gradual decline, but it occurs earlier. And premature menopause is menopause before the age of 40. And again, this curve would be shifted over. But in the case of women who undergo risk-reducing bilateral salpingo oophorectomy, risk-reducing BSOs, this drop in estrogen is quite abrupt. And as a result, it may result in sudden onset of symptoms of severe hot flashes, vaginal dryness, sexual dysfunction, sleep disturbances, increased risk for osteoporosis and cognitive dysfunction, as well as an increased risk of cardiovascular disease later on. So what are the concerns about the inadequate estrogen in young women? Well, the risks and advantages in the use of estrogen therapy in menopause prior to the age of natural menopause is different than the risks in older women. The term hormone replacement therapy, HRT, should be reserved for women experiencing premature or early menopause. Hormone therapy, or HT, is the term we use for hormone therapy in older women who go through natural menopause. And the difference is that in hormone replacement therapy, we are actually physiologically replacing the estrogen to reduce some of the side effects of early aging. And in older women, we're giving hormone therapy simply to mitigate menopausal symptoms. There are no studies that demonstrate an increased risk of breast cancer or peritoneal cancer with HRT in genetic carriers who undergo risk-reducing BSO prior to menopause. We'll refer to you as previvors because you don't have cancer, but there are few studies that have been performed. And the risk-benefit balance is definitely in favor of benefit of HRT prior to the age of 50 or 51. Women who have premature or early menopause have increased morbidity and mortality. Hormone replacement therapy is an effective approach to treating the symptoms of low estrogen and can mitigate long-term health risks, but should only be given if there are no contraindications to hormone therapy. For women who simply have menopausal symptoms such as hot flashes, we would offer non-hormonal treatment first, and also in the prevention of osteoporosis. There are no large-scale randomized trials in these women, and so there's a lot of uncertainty. We don't know the exact dose that we should be giving to these very young women of estrogen. We don't know the best route of delivery, and we don't know if we should be offering hysterectomy concomitantly with risk-reducing BSO. And in addition to this, right now, estrogen and other hormone levels are not recommended to be tested to monitor the effects of treatment. So this is a famous study from Dr. Roca in Olmsted County in Minnesota. And what he did was during these years from 1950 to 1987, look at women who had had both ovaries removed for non-cancer related reason. reasons. And what he saw was that in the women who had their ovaries removed prior to the age of 45, there was actually increased overall mortality. Now, this obviously was not specific to women who were genetic carriers because BRCA testing didn't start until 1996. So let's talk about hormone therapy and breast cancer, which is probably everyone's biggest concern. This slide shows the 22-year follow-up study of the Women's Health Initiative and its 2 randomized trials. This included women who had stopped taking hormone therapy after the WHI was terminated. And the women in the WHI on average were 63 years old, Caucasian, and tended to be obese. So it's not clear we can extrapolate this data to much younger women. So in the first part of the study, there was randomized use of conjugated estrogen alone plus progestin, medroxyprogesterone acetate, compared with placebo. And among these women who had their uterus, that's why they got the progestin, there was a significantly associated higher risk of breast cancer after 3 to 5 years of use, but no significant difference in breast cancer mortality. So you can see the orange lines after 3 to 5 years, the women on combination therapy continue to have an increased risk of breast cancer. On the other hand, the women who were randomized to the estrogen alone arm of the study because they previously had a hysterectomy had a significantly lower risk of breast cancer incidence and lower breast cancer mortality. And you can see them represented by the solid blue line here compared to placebo. In absolute terms, the reduction is modest, however. For every 10,000 person years of women following the use of estrogen alone, there were 2 fewer deaths as a result of breast cancer and 2 fewer deaths after breast cancer diagnosed from any cause. So, what about the BRCA previvors? It's important that young BRCA positive women are well informed that their overall cancer risk is reduced with the use of birth control pills, hormonal contraception, particularly the risk of ovarian cancer and endometrial cancer. The absolute breast cancer risk at the age at which hormonal contraception is used in women is very low. And so in the general population, the increased risk of breast cancer among hormonal contraceptive users is 1 additional case per 7,500 users of birth control pills. Breast cancer increases similarly within women who have either BRCA mutation. It's about 20% in women in their 40s, 37% by the age of 50, 55% by the age of 60, and more than 70% by the age of 70. Prophylactic BSO provides significant benefits in BRCA carriers with the view of reducing the risk for gynecologic and breast cancer, reducing risk of ovarian cancer by 85 to 95%, breast cancer by 53 to 68%, and removes occult or undetected cancers in 2 to 18% of women. And although risk-reducing salpingo-oophorectomy can significantly reduce these cancers, genetic mutation carriers who are under the age of 40 can understandably be reluctant to experience the significant menopausal symptoms and other health problems associated with removal of their ovaries. And especially, it should be noted that 10 to 24% of BRCA carriers of BRCA1 associated breast cancers and about 65 to 79% of BRCA2 associated breast cancers are estrogen receptor positive. So this may go into the decision of using long-term hormone therapy. Birth control users who carry the BRCA mutation have this reduced risk of ovarian cancer proportional to the duration of use. There's no evidence that birth control pills increase breast cancer risk in carriers or in the first 10 years after cessation of use. In a study looking at BRCA1 carriers who had risk-reducing BSO, estrogen alone seemed to be breast cancer protective, but there was a trend towards increased risk of breast cancer in women on combination therapy with the progestin, and it was about 10% higher in this study. In another study looking at combined 1 and 2 BRCA carriers who had risk-reducing BSOs, 14% who took any type of hormone replacement therapy developed breast cancer versus 12% who did not take it. And this was not a statistically significant difference. Hormone therapy of any type after risk-reducing BSO did not significantly alter the reduction in breast cancer risk provided by risk-reducing BSO after a follow-up of 3.5 years. So it takes a very long time to see these age-related changes associated with early menopause. And so short-term studies don't reflect these changes that can occur with early menopause. And there are no prospective clinical trials for long-term follow-up of early BSO. But the younger a woman is at the time of removal of her ovaries, the greater the age-associated risks. And these risks are independent of the indication for removal of her ovaries. So hormone replacement therapy can reduce early mortality, cardiovascular disease, stroke, cognitive impairment, and dementia, but it doesn't reduce the risk of anxiety, depression, and of the early onset of Parkinson's disease. So it's this balance which we are concerned about today. Let's talk about estrogen and cardiovascular disease. This is a slide from the very famous Framingham study, and in this part of the study, they compared women at any given age who were premenopausal versus postmenopausal, and you can see, even in very young women, there's a much higher incidence of cardiovascular disease in postmenopausal women, and that continues and increases compared to premenopausal women. There is evidence to support that if risk-reducing BSO is performed in women younger than 45 years of age, the risk for cardiovascular disease is increased. There's no obvious increased risk of death from cardiovascular disease if removal of the ovaries is performed in older women compared to women who have not had their ovaries removed, however. In the WHI, neither estrogen alone nor estrogen plus progesterone was found to reduce the risk of cardiovascular disease. But few of the women had had removal of their ovaries in this study, and it's not clear if the women in the WHI are representative of young women who experience surgical menopause in their 30s and 40s. Studies of the impact of oophorectomy on cardiovascular disease have not yet been reported in women who do carry the BRCA gene. So in this study, you can see that women who underwent risk-reducing or underwent BSO for any indication before the age of 45 had no increased risk of cardiovascular disease when it occurred later in life if they were treated with hormone therapy, but there was an increased risk if they did not receive hormone therapy. So what about fracture and the risk of osteoporosis? We see that women who go through menopause at the natural time have a gradual decrease of their bone mineral density due to a lack of estrogen. In women who undergo premature menopause, this curve is shifted over so that they undergo loss at a gradual rate. But in women who undergo surgical menopause early on, there's a very rapid decline of their bone mineral density, and the reason is that they lose their estrogen very quickly. All of these groups of women, by the time they're 65 years old, have the same bone mineral density on average and the same risk of fracture, but it's during this period of time that these younger women who have early loss of estrogen are at increased risk of fracture. So early menopause, especially when it's before the age of 45, is associated with as much as a threefold higher risk for any fracture compared to women who undergo menopause at a later age. The incidence of hip fracture for these young women can be as much as 6% higher compared to older women going through menopause. The risk for a spine fracture is 2.5 times greater in these young women. And in women at elevated risk of fracture, based on their age, significant reductions in fracture risk have been described with the use of hormone replacement therapy. And so this is looking at the use of hormone replacement therapy and bone mineral density in the lumbar spine and in the total hip. And you can see that at any given dose of estrogen, there is maintenance of the bone mineral density or even improvement compared to untreated women. Now, what about dementia, cognitive decline? Well, we know less about this than we do some of the other things we've discussed. Women who underwent either removal of one or both ovaries for non-cancer related reasons before the onset of menopause had an increased risk of cognitive impairment and dementia compared to the controls, and the risk increased the younger they were at the time of removal of their ovaries. Earlier age at menopause is also associated with an increased risk of Alzheimer's disease changes found at the time of autopsy. The use of hormone replacement therapy for at least 10 years when it started around the time of menopause is associated with less decline in global cognition. And there are no associations between the use of hormone therapy and cognitive outcome in older women undergoing menopause at a natural time of menopause. And so you can see in this study when women were giving, this is Dr. Rocco again, when women were giving estrogen up to the age of 50 years of age who had early menopause, there was no increased risk in cognitive decline or dementia using validated tools to assess this. But when they did not receive estrogen, they did have an increased risk later on in life. Let's talk about what we've often called vulvovaginal atrophy. It's now called genitourinary syndrome of menopause, or GSM, and the use of local hormone therapy. So these are biopsies of pre- and postmenopausal women's vaginas. In a premenopausal woman, there's increased blood flow to the collagen layer below the epithelium, the lining layer of the vagina. This increased blood flow allows increased moisture and elasticity in the vaginal wall. The epithelium covering the wall of the vagina is very thick. There's these structures called reedy pegs, which are associated with the elasticity and the moisture index. There's a full maturation of this epithelium, and glycogen is produced, which allows the normal bacteria or microbiome of the vagina, lactobacillus, to flourish. In contrast, in a postmenopausal woman, the vascularity of the collagen layer is decreased. There's less moisture, there's less elasticity. The epithelium is thinned out. It doesn't mature normally and produce glycogen. And so the microbiome actually changes in these women in the absence of estrogen. So how do we decide who's going to get local hormone therapy or vaginal estrogen? Well, we always try topical treatments first for symptoms of GSM, but and these are moisturizers and lubricants, which are over the counter, but when they fail, we have to consider the use of local hormone therapy. So women will present with the physical changes, physiologic changes associated with menopause. We see thinning of the vaginal and the vulvar epithelium. They may have symptoms such as dryness and burning and irritation. If they're sexually active, they may have pain with sex and dryness, and they may have bladder symptoms like overactive bladder and recurrent bladder infections. But we have to make sure that these symptoms aren't accounted for by another diagnosis. If she has a yeast infection, then we would treat the yeast infection, and that would better account for her symptoms in this case than giving estrogen. But local hormone therapy or vaginal estrogen has been proven to restore vaginal blood flow. It decreases the pH so that the microbiome can refer to lactobacillus, and it improves the thickness and elasticity of the tissue and the moisture index. It relieves the symptoms of GSM, and it can result in some bladder symptom relief, including fewer urinary tract infections, and treat overactive bladder. If the only symptom that's being experienced is GSM, and we're not having to worry about hot flashes or prevention of osteoporosis, then we would give local hormone therapy when it's appropriate, but this doesn't help with systemic symptoms such as hot flashes. There are two other products approved by the FDA for GSM. There's intravaginal DHEA, which is a steroid produced by the adrenal gland. It's used on a daily basis, and the DHEA is converted to testosterone and estrogen in the wall of the vagina, so its safety in breast cancer is not known. And then there's ospemifene, which is a SERM related to tamoxifen, which acts like estrogen in the wall of the vagina, and it's taken daily by mouth. Now, this is a list of the FDA-approved hormone therapies that we might consider using in someone undergoing early menopause. The non-oral routes of hormone administration avoid the first pass through the liver when it's absorbed through the skin, and it has minimal effect on liver proteins, coagulation factors, and inflammatory factors, which can increase the risk of other comorbidities. There's a lot of large observational studies which also show no increased risk of venous thromboembolism with transdermal estrogen. The patch is associated with stable serum estradiol levels. This can result in fewer migraine headaches because there's no fluctuation of estrogen, and it may be stabilizing menopausal symptoms. Oral estrogens, on the other hand, are metabolized first in the liver. They're absorbed directly into the liver through the gut. And the good thing is that they can increase HDL, good cholesterol, but they result in a 25% increase in triglycerides and increased coagulation factors and some inflammatory markers and venous thromboembolism risk. So I know you're familiar with these different types of transdermal sprays, mists, gels, patches, and also there's a vaginal ring. Oral estradiol is available. There's oral and vaginal conjugated estrogen, both equine estrogen used in the Women's Health Initiative and synthetic conjugated estrogen. There's vaginal estradiol. These are new terms. So ospemifene and raloxifene, related to tamoxifen, are called SERMs, selective estrogen receptor modulators, and the new name are ERAs, estrogen receptor agonist and antagonist. And then there's a drug called Duavi, which you may have heard of. It's conjugated estrogen plus another SERM, which is approved by the FDA for menopausal symptoms. And this is called a TSEC, a selective tissue selective estrogen complex. And you're familiar with the progestins and progesterone. They are FDA approved. The intrauterine device, the hormonal intrauterine device, is interesting because we use it frequently to protect the endometrium in women who are on estrogen, but it's actually not FDA approved in the United States for that purpose. It's only approved for contraception and management of menstrual symptoms. However, the data is very good that it does protect the endometrium, and it is widely used for that purpose, but it's off-label. Now, many of you have questions about the compounded bioidentical hormones. This is a marketing term that was created after the WHI when women were very afraid to take FDA-approved hormones because of the risks that they had learned about when the WHI was discontinued. When I talk about bioidentical hormones, I'm talking about hormones that are structurally the same as those made in the human body. But in this term, we're really talking about hormones that are not FDA regulated and not manufactured in factories and in labs that have FDA oversight. They're manufactured on an individual basis. They're not manufactured in batches. And the concern is that there's a lack of regulation and monitoring, the possibility of overdosing and underdosing. There's a lack of efficacy, of scientific data about efficacy and safety. And finally, there's no package insert that comes along with any of these hormones. And again, a lot of integrative medicine providers are testing serum and hormone and salivary levels of hormones, and there is really no indication for doing that. What are the contraindications to using hormone therapy in menopause? They're very similar to the contraindications of the birth control pill. Obviously, known and suspected pregnancy is not relevant in women who have had their ovaries removed, but any unexplained vaginal bleeding has to be worked up to make sure there's no abnormal tissue. Liver disease would be, since estrogen is metabolized in the liver, would be a contraindication. Any history of cardiovascular disease, blood clot, stroke would be a serious block. If you're allergic to the medication, if you have a history of breast cancer, estrogen-dependent tumor, endometrial cancer, then we would rarely use it, but certainly discuss with your oncologist before instituting that. So what are the doses that we use? American College of OBGYN says that when we're giving hormone replacement therapy in very young women, we can use oral estrogen. They talk about estradiol, 1 or 2 milligrams. Most commonly, we use a transdermal patch. This would be the 0.1 transdermal patch, or you could use conjugated estrogen, such as was used in the WHI. The 100 microgram, the 0.01 transdermal patch can be considered full dose physiologic replacement for young women. And on average, this achieves a serum estradiol level of 100 picograms per ml, excuse me, near the normal mean estradiol level for women who are cycling and menstruating, and their average level is 104 picograms per ml. Transdermal and transvaginal estrogen is the preferred route of delivery due to avoidance of the first pass through the liver. And interestingly, the birth control may have less beneficial effect on maintaining and improving bone density, but many women who have early menopause choose to go on the birth control pill, and that's fine. There's minimal systemic absorption of local hormone therapy. It raises the serum level just for a couple of days and quickly returns to premenopausal levels, and is not different from women who are not on local hormone therapy. The problem is that the FDA has given us the same package insert and warning that they give on birth control pills and on hormone replacement therapy. And it talks about dementia, blood clot, stroke, breast cancer, endometrial cancer, heart disease, when really none of these risks have been associated with the use of local hormone therapy. However, there's no data regarding the risk of breast cancer in women who are already high risk for breast cancer with local hormone therapy. So these are the products that you may be familiar with, the local estrogens. There's tablets, there's a ring that you change every 3 months, there's creams, and then this is the ospemifene, which is taken orally, and the DHEA that I mentioned to you before. If we look at systemic absorption of estrogen, this is with the vaginal ring, you can see that just for a few days, there's a peak in serum estradiol, and it quickly returns to to postmenopausal levels. And this is looking at the vaginal tablet, and 1 year after use of vaginal estrogen, there was no increase in serum estrogen levels in women who were users compared to women who were not users. So what's on the horizon? There is a study going on right now. It's for BRCA1 carriers, and right now the standard of care is to recommend risk-reducing BSO to BRCA1 carriers between the age of 35 and 40, but there are women who decide to delay, defer, or just not to have risk-reducing BSL because of the consequences of early menopause. And so in this study, women who have declined risk-reducing BSL are offered removal of both of their fallopian tubes only because it's felt that ovarian cancer arises in the fallopian tube. So that's kind of what's on the horizon out there right now that I know of. All right, so in conclusion, if a woman is to undergo a BSO before the age of 45, she should consider hormone replacement therapy up until the age of natural menopause, unless there's a contraindication because it mitigates menopausal symptoms, improves quality and duration of life. And although there's a number of alternative options to managing menopausal symptoms, hormone therapy is the most effective modality in managing menopause-related symptoms. The use of hormone therapy is a shared decision-making process and it has to include counseling on the other options that aren't hormonal. And also we need to discuss there's a lack of population-specific data regarding hormone therapy, especially in regards to genetic carriers. Estrogen alone appears to incur a lower risk of breast cancer than estrogen plus progestin, and that gives us consideration to prophylactic hysterectomy. So currently, based on survey studies, about 50% of women with BRCA mutations elect to undergo hysterectomy at the time of their risk-reducing BSO, and about 40% of providers recommend hysterectomy at that time. Although women planning to take tamoxifen and those with known diagnosis of Lynch syndrome are most likely to benefit from additional risk reduction with hysterectomy, the benefits must be weighed against the potential surgical risks of adding hysterectomy because there's a 2 to 3% increased chance of adverse outcome. Because there's no large-scale trials, optimal hormone therapy dose remains unknown. The tentative recommendation, as I've discussed, is the 0.1 transdermal patch, and there's no data as to what appropriate estradiol levels would be routinely, so we don't check it. If non-hormonal treatment for GSM fails, local hormone therapy is a safe option for breast cancer previvors. And I thank you for your attention and look forward to answering your questions.